All right. Hello, everyone. So, I'm Dr. Tushar Mehta. I'm an orthopedic surgeon and your faculty for orthopedics. Today's video is about oncology, orthopedic oncology, bone tumors, and we are going to discuss benign tumor, a small tumor, usually affecting the small bones, short bones, tubular bones, particularly hand and feet, though hand is more commonly involved as compared to feet involving phalanges and metacarpals. Again, we've observed that phalanges more than metacarpals. X-rays there on the screens right now. I hope you can appreciate something over there. All right, guys. So let's start talking about enchondroma. Well, any age group. I mean, if you ask me, and whatever my clinical experience is, any age group. Yeah, they say that peak is in between 10 to 30 years, but I've seen people of 14 years, of 40 years, of 64 years. So according to me, any age group. So they contribute to around 5% of all bone tumors and almost 17.5% of the benign bone tumors. Clinical spectrum, if you see for an enchondroma, majority of them are incidental findings. Even if they're there, they're usually silent. As you know, I told you that's a classical benign tumors. You get an X-ray done for some other obvious reason, and you come across that you have this. So majority, as I said, are silent. They're asymptomatic. So what is that one thing that makes them symptomatic? That usual thing that makes them symptomatic is a pathological fracture, which I hope you must have appreciated in the opening slide. So it was silent, asymptomatic enchondroma, but it got complicated with the pathological fracture. The second thing that make them complicated after pathological fracture is a malignant transformation. Very rare. You see that thing occurring very rarely. So majority of them are asymptomatic, clinically silent, incidental diagnosis, complicated by pathological fracture. Now, what is going to happen if a otherwise clinically silent enchondroma will develop a pathological fracture? There's only one thing that can happen is it'll be painful, and you will go for an X-ray and you will find that it's not a simple fracture, it's a pathological fracture with a underlying triple enchondroma. But if you have an enchondroma and if it is painful and you cannot see the pathological fracture on an X-ray, then you should think of the malignant transformation. Well, why the word enchondroma? Very simple. Chondro means cartilage, oma means tumor, and means inside. So enchondromas, they arise from the rests of the growth plate cartilage on the chondrocytes, and then of course, as it happens with any tumor, these chondrocytes, they proliferate and proliferate and proliferate, and then they slowly enlarge, and they have a mature hyaline cartilage. So technically, you can see enchondroma in any bone which is formed from cartilage. A typical appearance of an enchondroma is a less than 3 centimeter, translucent, nodular, and usually grayish blue. Well, enchondroma is definitely important. Clinically, we see them often, but what is that one thing which is associated with enchondroma is the syndromic association. Not only you get MCQs, you get Viva questions also on this. So there are two syndromes which are classically associated with enchondroma. One is the Olier's disease, and the other one is the Maffucci syndrome. So you can very well observe that all these bones, they have the appearance of development of multiple enchondromatosis. That is what is called as Olier's disease. But when you add cavernous hemangiomas, which I'm sure you can appreciate here, and you add phlebolith, phlebo by the way means vein, lith means stone, so stoned veins, calcified veins. So just multiple enchondromatosis is Olier's, but when you add phlebolith and cavernous hemangioma, it becomes Maffucci syndrome. Now, as I said that usually small tubular bones are involved in enchondromas, so they are usually seen in the small tubular bones, hand more than feet, phalanges more than metacarpals, located always inside the centrally inside the medullary. cavity. It's not that large bones cannot be involved, but usually we see in small tubular bones, as I mentioned. There's something which happens very rarely. I mean, the name itself is N inside chondroma, but something that happens rarely, that it can extend through the cortex outside and demonstrate a kind of a exostotic growth or an exophytic growth. Now, in that way, we will call it Enchondroma protuberance, which is very, very rare thing to be seen. Now, typical radiological picture, if you will ask me, I will be dividing this radiological picture into two parts. One, when you see an enchondroma in a typical location, that is in the phalanges or metacarpals, you will find them classically expansile and purely lytic. Simple. Very, very simple. So if you find in other locations, then of course they are expansile, they are lytic, but they have certain sort of, calcification called as ring and arc calcification. So as I said initially also, and I will repeat my words again, that when you see an enchondroma, you will always find this enchondroma inside the medullary cavity of a small tubular bone like a phalanx. So one thing I'm sure you have observed. Second thing, it is purely lytic. I'm sure you can very well imagine that it is purely lytic. And of course, needless to say, it is expansile. Okay, so again, you can appreciate it here also. Purely lytic lesion involving the distal phalanx and expansile also. Now, any other area, if you see apart from these small tubular bones, then it will be having expansility but with rings and arcs calcification. But a typical enchondroma is a 1 to 2 centimeter lytic lesion without any signs of aggressiveness. Like for example, you will have a narrow zone of transition. You will have a endosteal scalloping, or you can say a scalloped margin. There can be an expansion of the underlying cortex if you see, and at places you will see thinning of the cortex also, but pathological fracture happens late. So no periosteal reaction, which is one of the differentiating features with another condition called as tubercular dactylitis. You can see that there is cortical thinning, there is endosteal scalloping, there is no soft tissue mass usually, there is no invasive process usually, there are no signs of aggression usually. So this is how you describe an X-ray. So if you will ask me, I will say that okay, fine, this is an X-ray of the proximal phalanx. I mean, this is an X-ray of this entire area of the entire hand, but in this proximal phalanx I can see a well-defined geographical lytic lesion with pure lysis in itself, with cortical thinning, with endosteal scalloping, without any periosteal reaction. So this is how I would like to explain this. Now, majority of the enchondromas, they usually arise in the metaphyseal area because of the proximity to the growth plate. So that is again something which we should be aware of. You will very rarely see an enchondroma in the epiphysis, and I'm sure by now you must have understood that any cartilaginous lesion in the epiphysis will take you towards the probable diagnosis of a chondrosarcoma. Two investigations after X-ray. One is MRI. Very simple, that is investigation of choice. Why? Because it will tell you whether there is any soft tissue extension or not. Then nuclear medicine, of course, you have to see whether the lesion is multiple or not. Then bone scan is going to be helpful. So X-ray is the basic investigation, MRI is for assessing the soft tissue invasion, and bone scan is for assessing the multiple lesions. Two complications, as I said, the one which happens frequently, the one which we see frequently, and it's a typical clinical picture. Otherwise, a clinically silent asymptomatic incidental diagnosis and enchondroma presenting with pain, usually due to pathological fracture. And if there is pain but there is no pathological fracture, then the second possibility is malignant transformation into chondrosarcoma, although that is very rare. Now, as far as treatment is concerned, I'll be very honest in telling you that sleeping lions, why to disturb them? If it is asymptomatic, let it be. Just keep a watchful expectancy, wait and watch every 3 to 6 months, get an X-ray, clinically ask questions that any rapid change in the size or any clinical symptoms. So just keep a close watch, that's all. But yes, if there is a fracture, then my suggestion always is that let the fracture heal and then you treat the underlying lesion, that is by curettage and bone grafting. And definitely, if there is a syndromic association or some malignant transformation, which happens very rarely, then treatment is aggressive, and whatever the clinical picture that you get, you treat it accordingly. But otherwise, leave them as such, nothing much to be done. And if they are clinically symptomatic, then curettage with bone graft is usually sufficient. So, very small video about a very small tumor, the most common bone tumor of hand bones, the most common benign bone tumor of hand bones, usually seen in hand more than feet, phalanges more than metacarpals, arising from chondrocytes and chondromas. So thank you so much. Coming up with more videos soon. Stay tuned to the YouTube channel. Bye bye. God bless.